Okay, good morning, friends. Happy to see you all again. We are back after a gap of one Saturday that we missed because of the floods in Vadodara. So today we have Dr. Jalpa Dave with us. She is a very well-known young pediatric nephrologist. She is known not only in Baroda, but well-known across the country. And she has affiliations in Vadodara with KGP Children Hospital, Parul Sevasram Hospital, and all major pediatric ICUs in Vadodara. Her areas of interest are critical care nephrology, glomerular disorders, and management of congenital anomalies of renal, kidney, ureter, and bladder. She has many publications to her credit, which have won some prizes also at national and international levels. And of course, she's a very popular speaker at various fora across the state and India. With this brief introduction, I will request Dr. Jalpa to start her talk on urine routine. Is it so routine? I mean, the title is very catchy, and often we take urine as a very routine examination. But she will be throwing a lot of light on how to interpret urine examination results and how does it help in several conditions for diagnosis. So over to you, Dr. Jalpa. You have about 40-45 minutes, and then we'll have discussion for 10 minutes.
Okay.
Over. Yeah.
Thank you so much, sir. Thank you for the kind introduction. It's always a pleasure to be here in Saturday Club Meet and present our work. So without wasting much time, I will share this screen and presentation. So the topic of today's presentation is urine routine. Is it so routine? It's so frequently, like we day in and day out during our OPD practice, we prescribe urine routine so commonly. Like in case of pediatric, we prescribe it whenever there is burning micturition, crying while micturition, or fever of unknown origin in infants and in adults also. Especially the elderly females and males, if they have on and off burning micturition, it is very commonly prescribed. But it is not only about pus cells, protein, and glucose. There is so much more to urine routine micro. And if given significance to each and every component or components of the urine routine microscopy report, it can help us making a difficult diagnosis, or sometimes even catching up those misdiagnoses which can be there. So, what are the details of urine routine micro report? It's not only about urine routine. Actually, it contains at least 12 to 13 characteristics. Like, in urine biochemistry, or you can see chemical examination, there is the appearance which matter, the pH of urine, specific gravity. By dipstick, you will come to know about urine protein, urine glucose, urine ketones, urine bilirubin, bilirubinogen, blood, and leukocyte esterase nitrite test. Along with that, microscopy include pus cells, red cell, epithelial cell, crystals, cast, and each of this component can lead us to various diagnosis in a given patient. So before going to the report, what is the process? The process of urine formation includes three components: urine production, urine refinement, and urine elimination. The production mainly will occur at the glomerulus, along with the help of glomerular basement membrane, the barrier, the arterioles, Bowman space, etc. Urine refinement, which will be occurring mainly in renal tubules with the help of your proximal convoluted tubules, your loop of Henle, your distal convoluted tubules collecting the urine elimination, which is mainly with the help of your urinary tract, that is pelvis, ureter, urinary bladder, etc. Going with the flow, how to collect the sample of urine. For adult, it is very easy in an adult patient that you just advise them to collect the midstream sample. But especially in pediatric, and this is a case scenario, the pediatrician and as a pediatric nephrologist, I also come across so often that a 6-month-old male patient who had presented to your OPD with a fever of almost 39.5 degrees centigrade, and prenatally there was left hypernephrosis visible. This parents have noticed crying while micturition. On examination, there is irritability. The rest of the systemic examination is normal. He is uncircumcised, a urinary tract infection is strongly suspected. So how will you advise to collect the sample? In a 6-month-old male baby, the baby is not admitted yet. So it's a mammoth task. For us, it's easy to tell parents that hame urine api dejo, urine routine culture karavi lejo. But when it comes to collect a sample of an infant, it's indeed very difficult. So what parents end up doing, either they just apply the minicom or the perineal bag and then transfer that sample into the container, or they just put some vessel, especially in periphery, and then they transfer from that vessel the urine to the urinary cup. But actually, that is not ideal. So, what I tell them is, mothers do know when the kids are young, say after giving feeding, say after 20-30 minutes, the baby will pass urine. So, I tell them that you keep the diaper or open, keep 2-3 urine container with you. And whenever the baby passes, it may take 1 hour or sometimes 1.5 hours, but usually by that time you will get a sample. So rather than applying perineal bag or minicom, it's better to wait for a while and collect a direct sample from infant as well. If you cannot do that, then it's better to collect it with the help of IFT, that is infant feeding tube with the catheterization. Suprapubic aspiration, which was very commonly used, but nowadays it is very, first of all, it is a bit cumbersome. It's a bit invasive for parents, though it is the gold standard. For suprapubic aspiration, you are going to puncture and then take the sample, especially in case of newborns. So nowadays it is not so commonly used. So best is midstream or catheterization if the patient is admitted. So we all know the gold standard is suprapubic, followed by catheterized sample properly collected, followed by midstream, and perineal bag has got a very poor specificity which should not be used. This is the various IFT size which one can have a reference for if they want to collect the urine sample according to the patient age. So for children who are less than 2 years, you should not use a size more than 6 French or rarely 8 French. Coming to transport, it is as equally important how you are collecting the sample and then how you are transporting. It should not happen that the sample has been collected in the morning and then you are, while going to office or work, after 4-5 hours, you send the sample to the lab. So the transport should happen within 2 hours. And if it is not feasible to transport within 2 hours, you should refrigerate it at the normal refrigerator, not in the deep freeze, at the 4 to 6 degrees centigrade. And it should be transported within 6 hours. Very rarely, few books also say that it can use up to 24 hours. But I would suggest that it should be transported within 6 to 8 hours when the refrigerated sample. And the amount also should be sufficient. Like at least 10 to 20 ml of urine should be there. Timing of collection. Significance of first morning sample, especially in case of this diabetes, as well as to detect proteinuria, mainly for urine protein create ratio or urine albumin create ratio. Whenever we ask for a first morning sample to eliminate the orthostatic proteinuria, which can be there in any healthy individual by the evening or so. But in case of UTI, you should not wait before starting antibiotics. So if the baby comes to you in your evening OPD with high-grade fever, you are suspecting urine routine, you can straight away ask them to give the sample of evening as well to diagnose the UTI. And sometimes we also advise for 24-hour urine protein collection for various diseases like systemic lupus erythematosus or other kidney issues. So that should be collected. That should be ideally started from the morning. One should avoid the first morning void. One should collect all the samples of urine throughout the day, including nighttime sample, and they should collect the first morning of the next day. So that's how a proper 24-hour collection should be done. Many of us, especially in nephrotic, I do advise parents to use urine strips to detect the urine albumin. So how it should be used? It should be used immediately. Like it should not happen, you have dipped this urine strip. So in this slide, you can see that you should read it within a minute. Some, like especially ketones, bilirubin, glucose, should be read within 30 seconds of dipping the strip. and protein, etc., within a minute or so. It should not be kept more than 1 or 2 minutes or more than a minute before reading the urine strip. Now let's declutter the whole urine report, and first we will go in the urine chemistry, or which usually is done nowadays by automatic flow cytometry, followed by the urine microscopy, which is again manual. So chemical examination contains various like urine glucose, bilirubin, protein, etc. This is a very interesting case which came to me just recently, say 2-3 months back. She was an 18-month-old female child without any complaints. Only thing, the urine routine was showing glucose, like 3-4 urine routine were there, which was showing 3+, 4+ glucose, not even protein. She is just 18-month-old kid. So what will you do next? You will definitely ask for the random blood sugar, whether the RBS is normal or not. It was normal. Coming to detailed history, this 18-month-old girl did have past 3 to 4 urine sample, because one incidental urine which was done for fever showed glucose. So the pediatrician thought, let's repeat it in the following sample, and it persistently showed glucose 2+, 3+. There was no history of polyuria or polydipsia. There was no history of recurrent urine infection. The weight was a bit lesser side, that is like less than 3rd centile, but there was many issues with the diet as well. These are the reports I asked for. The CBC was pretty okay, with normal creatinine, with normal electrolyte. There was a mild acidosis which was there. Vitamin D was a bit on lower side. The calcium create ratio was a bit higher for her age, and the protein create ratio was okay for 18-month-old. So by and large, I made a diagnosis. Sometimes what happened that vitamin D deficiency can also lead to some form of proximal RTA-like picture transiently. So with the help, with the report of a bit more calcium in urine, I started on Portrait syrup, but I had also asked them that if this thing persists, it's better to go for genetic evaluation, because there is a condition known as familial renal glucosuria. So she was started on vitamin D supplements and Portrait syrup for that hypercalciuria element of a bit. And genetic workup was explained, and it was sent because even on follow-up, this glucosuria was there. And here is the report. It came positive for SLC5A2 mutation, and it is responsible for the SGLT2 co-transporter, which is there in tubules, which is involved in the sodium glucose transport at the tubules. And this gene mutation can lead to familial renal glycosuria. So sometimes glucose in urine in pediatric needs proper evaluation. Coming to ketones in urine, it is very helpful to differentiate between diabetic ketoacidosis, starvation ketoacidosis. Even it is very useful in managing diabetic ketoacidosis, when to stop urine IVL insulin, especially in patient of pediatric, when your urine ketone become less. That is one of the indirect sign you can safely shift the kid on sub-Q injection instead of IV insulin. Coming to pH, though it is a very helpful marker, but the drawback of this test is that it should be checked immediately, and most of the time logistically it is not possible until and unless you have pH meter with in your setup. So the pH varies between 5 to 8. Usually it is acidic. If it is really very alkaline, say more than 8, then one should suspect infection with urea splitting organism, we all know. Coming to specific gravity, again same like pH. It is one of the very wonderful tests to know many things about the urine status, urine concentrating ability, but again it needs to be freshly checked in a freshly voided sample with the help of refractometer. The lowest possible specific gravity in a normal individual is 1.002 and highest is 1.040, and it varies between this range. These are various causes. If there is persistently low specific gravity, it shows there is concentrating ability of urine is affected. Maybe diabetes insipidus in nephrogenic or central, or excessive water intake. If your specific gravity is too high, then it is a, like in case of SIADH or severe dehydration, CCF, etc. And if it is sometimes, there will be isostynuria. Your specific gravity will be fixed at one point. That especially occurs when your tubules are affected in case of acute tubular necrosis, in sickle cell disease, sometimes in our chronic kidney disease, when your tubules are ultimately gone and they cannot function at their optimum, and hypercalcemia. And the causes of falsely high specific gravity is glucosuria. And if you have paid attention in this patient urine report, if you see the girl with glycosuria, the specific gravity has been mentioned is more than 1.030. So sometimes we just don't pay attention to all the reports, but it can lead to the diagnosis. So this was for me, it was definitely, if there is a glucosuria, you can get falsely high specific gravity. Now coming to our next part of urine strip, that is urine bilirubin. This was a 6-year-old female admitted at hospital with a past medical history of recurrent infection, urinary infection. But right now she presented with acute pain in abdomen. On your initial evaluation, you note there is mild icterus there. She is having jaundice. She is having acute abdominal pain. She is having low-grade fever, vomiting. Urine routine was sent. It came normal. If you see, the pus cells are not there, so there is no urine infection right now, but bilirubin is 3+. Acute pain in abdomen, vomiting, low-grade fever, with jaundice, with urine bilirubin positivities, some form of obstructive jaundice element, and most common cause may be in pediatric, it can be the CBD stone. So we sent the investigation. Her SGPT was a mildly on higher side, with alkaline phosphatase being very high, suggestive of obstructive component. Her conjugated hyperbilirubinemia was evident in blood. Albumin was normal, showing it is not something properly, chronic liver element which is there. Her CBC CRP was not very much affected, and USG confirmed our diagnosis was CBD stone. If the same girl would have sickle cell, because we did have 2 patients simultaneously, if the girl is having some sickle cell disease per se, then what will you find the difference in report apart from urobilinogen? You can have protein as well as you can have urine urobilinogen. So this we studied in MBBS time, especially during a pathology exam, that it is so important to know what is the difference between urobilin and urobilinogen, and you can actually make the diagnosis. In case of sickle cell disease, there will be definitely obstructive component because of CBD stone, but there is also a hepatocellular component because of sickle cell hepatopathy, and you can have both. In case of post-hepatic jaundice, which was there in our case, there was only urine bilirubin. The bilirubinogen was negative. And if you have a patient of hemolysis crisis, you can have urine urobilinogen present, which can indirectly support your diagnosis. Coming to this strip, which is very widely used by a nephrologist in office practice, sometimes it is mainly urine nitrite and urine leukocyte esterase strip to diagnose UTI, though they have their own fallacies. This is one OPD case of 15-year-old female who came with dysuria with increased urinary urgency. The dipstick showed 2+ leukocyte esterase with positive nitrates. So nitrite is positive. So from this report, definitely she is having urinary tract infection. But you want to start an antibiotic and you want to know whether there is gram negative or gram positive. Can you diagnose with the help of positive nitrite? Definitely yes, because nitrite can come positive only with the help of gram-negative neuropathogen. So if you have a positive nitrite test, it indirectly suggests an infection with a gram-negative organism, which is also very common. So that is one important point and helpfulness of this both test. False negative nitrite can be because of diluted urine, less bladder incubation time, or decreased pH and low dietary intake of nitrate per se. Coming to leukocyte esterase, what can be the fallacies associated with this test? So this is a 14-year-old female, a known case of systemic lupus erythematosus. She was admitted with high-grade fever She received rituximab injection 15 days back. So she was definitely immunosuppressed at that time. And her absolute neutrophil count on admission was only 90. And her fevers had been as high as 39 to 40 degrees centigrade. So as a part of the workup, first of all, because she was neutropenic, we started her on piperacillin amikacin after sending blood culture, urine analysis, chest X-ray, CBC, CRP, everything. Her urine routine showed negative nitrite as well as negative leukocyte esterase test. And her microscopy was also normal. There was no pus cells. She had some mild dysuria, but otherwise she was okay. Main complaint was fever. So because the urine routine was absolutely normal with negative nitrate, we didn't send the culture. It was not sent. Was it a right decision? No, because the girl was neutropenic. If her neutrophil count is 90, how can you expect a pus cells in urine routine? So this is a very important. The girl basically we did send urine culture and it grow organism and she was having bad UTI, in fact pyelonephritis. But many a times in a neutropenic patient, your pus cells can be normal because there is not enough neutrophil to be excreted. Your dipstick will be negative because ultimately it's detect from the neutrophil itself. So that is very important point, the importance of urine culture to diagnose UTI. Something regarding leukocyte esterase, that it has to be at least 10 leukocytes per cubic mm in your urine routine. So then only your leukocyte esterase will come positive. So this girl didn't have that much leukocytes in her urine and we had a false negative urine routine report. Now coming to the most frequent and the most dreaded complaint of parents, especially for us in pediatric, is hematuria. The spectrum of red, whether it is naked eye to machine eye, whether it is gross hematuria or microscopic hematuria. I have taken few case snippets, which can give us a spot diagnosis of the cause for hematuria. This is a 7-year-old boy who presented with fever, red color urine, myalgia following his annual sports day. His urine dipstick showed 3 plus blood, but microscopy didn't reveal any RBCs. And his serum create
Can't hear you, Jalpa. Hello. Hello. Jalpa, your screen is just stable. I mean, we can't see you. It's progressing. So it seems you are disconnected. So your slide was on 7-year-old with red colored urine. So I was trying to figure out whether it's my connection is unstable or what. But it seems that nobody is able to see you. So please log in again, I think. Okay. She's logged in again. Please wait.
I have just called Jalpa to log out and again log in.
Yes, yes. I also called around. Yes. Jalpa, we are able to see you now.
Okay.
But the screen is not moving. Just try to see the slide.
Yes, sir. Yes, sir. I'm so sorry. I guess. Sir, this was the 7-year-old with. Is it visible now?
No, we are not seeing. I think we'll wait. Currently, we are not able to see your screen.
Okay. It is showing the screen is being. I will just start again. Start.
You need to start again.
Yes, yes, sir. So sorry.
Yes.
So is it visible now, the screen?
Yes, it's visible. Just
Yes, sir.
try
So,
to move the slide and let us see whether it moves well or not.
yes, sir.
So we were actually go to the earlier slide, 7-year-old with hematuria.
Acha,
Yeah.
Oh, I'm so sorry. Okay.
Yeah. This is where we stopped. Yeah.
Okay.
The next slide.
Okay. Okay. I'm sorry for the inconvenience. So this was regarding hematuria, which is very commonly encountered in our day-to-day practice, and you should be very vigilant to pick up the few hidden signs in the urine report. So this is a 7-year-old boy with fever, with red color urine, with myalgia following his annual sports day the previous day. His urine dipstick showed 3+, but there were no RBCs. A creatinine was a bit on higher side, so it can be mainly because of myoglobinuria rather than a proper hematuria leading to any proper kidney issue. The same age, 7-year-old male with red color urine, with fever, cough, cold, with blood pressure being a bit on higher side, 128 is a bit high, with history of skin infection 1 month back, with 3+ blood, 2+ protein will be mainly because of post-infectious glomerulonephritis, that is PIGN. A 7-year-old with burning micturition with red color urine who has taken fever medicine for 2 days, which is now most commonly sometimes it is ibugesic or Meftal with no pus cells but 30 to 40 RBC. If there are no other red flags, it can be because of drug-induced hematuria. And same, a 4-year-old male with hematuria with family history of calculus, with USG suggestive of bilateral concretions, with 3+ blood, with 50 to 60 RBCs, with calcium oxalate crystals on urinaries, mostly because of hypercalciuria, which is one of the very common cause of microscopy and sometimes gross hematuria in case of pediatric age group. So this is a flow chart. If you are having microscopic hematuria in a kid or adult, if you are suspecting glomerular hematuria with this a long history of joint pain or other systemic illness like rash, if you're suspecting encapsulitis or lupus, or if you're having positive family history, then it can be Alport or IgA nephropathy or simple PIGN. If there are no the signs of glomerular hematuria, then the hematuria can be lowered down, that is the tubular hematuria, which is the most common cause for tubular hematuria is your urinary tract infection, your hypercalciuria, your calculi. Sometimes in sickle cell disease, because of papillary necrosis, you can have persistent microscopic hematuria. And in adult, it is very important to rule out malignancy. And microscopic hematuria, if it is persistent, if even for say 2 to 3 months, then you should evaluate properly. Apart from hypercalciuria, there are few conditions like Alport syndrome or sometimes IgA nephropathy, which can present with persistent microscopic hematuria. So it's very important to document the protein create ratio as well. Coming to urine protein, itself a book by itself, but I have tried to concise it in 3-4 slides. So these are protein value for 8 different age group. That if you are having a 700 milligram of protein in a premature infant's urine, then it is normal because tubules are not yet matured. So it's okay to have some form of proteinuria in an infant, but again, you need to correlate it clinically. And for more than 5 years, if your protein create ratio is more than 0.2, then it is abnormal. So this is a case scenario. An 8-year-old boy with gross hematuria for 2 days, with hypertension, with edema, with 2+ urine albumin. The cause for albuminuria in this patient may be nephritic syndrome. At the same time, a 7-year-old healthy baby with the only complaint of puffiness of lids in morning for last 15 days to a month, with no fever, normal BP, the cause may be nephrotic syndrome. Having said that, this is very important. I would like to stress upon the third case. A known case of POL fulguration, which was done at 3 years of age, had came to you at 9 years, and you just did urine routine for fever, and you have found 2+ urine albumin. His serum creat is 1.2. The cause for urine albumin is in this patient is not acute. It shows that the kid is going towards a downhill course, and he is developing those signs of end-stage renal disease because proteinuria will be the first thing affected when a patient is having some chronic issues. So it's very important to document urine protein creatinine ratio regularly in all those your pediatric patients who are having some form of congenital anomaly of kidney and urinary tract, that is CACID. So this is a flow chart for proteinuria. So what are the causes of pathologic proteinuria? So, and what you will ask, I would just go through, like you will ask for urine analysis, you will ask for C3, C4, ANA, dsDNA to know the, acute cause of any other systemic illness leading to kidney issues. You will ask for low molecular weight proteinuria, especially in case of adult population. will ask for sonography and SOS genetic evaluation. And you need to biopsy if any of this, if there is persistent microscopic hematuria, if there is persistently low C3, if there is associated hypertension, hypoalbuminemia, then one need to do timely biopsy so that you can timely give immunosuppression and save the kid. So this is all about your chemical examination of urine. Now coming to urine microscopy, pyuria, the burning truth. It is defined if your pus cells is more than 5 in a centrifuge sample. Sterile pyuria if there is presence of pus cells in urine with negative urine culture. So is this a UTI? A 4-year-old male with high-grade fever, with burning micturition, with 60 to 80 pus cells, with few RBCs, definitely this can be UTI. You need to send culture. A 8-year-old boy with fever for 3 days without any urinary complaint. His leukocyte esterase is positive. His urine is showing 8 to 10 pus cells and urine culture is no growth. So it's a very dicey. You need to properly evaluate because sometimes fever itself can lead to some pus cells in urine. And if there is no urinary symptoms, you need to don't treat as a UTI, but definitely you should repeat one urinary after the fever episode is over. And this is again an interesting, a 1-year-old female with multiple urine routine showing pus cells and there were no symptoms to her. She was operated for some anorectal malformation, mainly cloaca, and her urine culture is always negative. USG KUB is normal. So this girl is having sterile pyuria because of that rectovaginal fistula. She was not having UTI, so there was no point of treating that girl for that pus cells which was there while she actually didn't have any urinary symptoms. So, આપણે રોજ જોઈએ કે યુરિનમાં pus cells છે, but what does that pus cells actually comprise of? So all those pus cells which they mention, it is basically neutrophils, which is most common. Sometimes eosinophils, but again you need a special stain for that. And it is more common in all those eosinophilic cystitis, sometimes chronic interstitial nephritis. So we do send urine eosinophils if we suspect some form of tubulointerstitial nephritis, and it is, if it comes positive, it is re-diagnostic, but if it comes negative, it doesn't rule out your interstitial nephritis. Lymphocyte, again, not easily seen. It requires special stain, and epithelial cells such as contamination of skin rather than a proper issue, especially in pediatric people, not in case of adult. So the pus cells mainly are neutrophils. Coming to sterile pyuria causes, the infective causes of sterile pyuria, the paradoxical name is, so the atypical organism leading to UTI like your viral, your fungal, your parasitic, your genitourinary tuberculosis, sometimes STD in elderly pediatric, like especially adolescent pediatric patients, and non-infective causes of sterile pyuria, the most common being acute interstitial nephritis, followed by hypercalciuria, followed by few other like analgesic nephropathy, Kawasaki disease, SCD, and iatrogenic, sometimes because of indwelling catheter, intermittent, that is CIC, intermittent catheterization. If you are having some ureteral stent, especially DJ stent following pyeloplasty, etc., and strenuous exercise. Last few 2 components are remaining. Should I continue? I don't time.
Yes, please continue. Finish the topic.
Yeah. So cast in urine. So this is cast are basically they are forming your distal convoluted tubule or collecting tubules, and they are composed of an external backbone of your Tom-Hochfeld protein, which is secreted mainly in the DCT. So factors that favor cast formation are stasis, urinary stasis for any reason, high salt concentration in urine and low urinary pH. And it is, indeed, it was supposed to be non-invasive liquid biopsy, but nowadays we don't pay much attention. But I will share a few case scenarios in which I had found them very useful. So the cast can be cellular or non-cellular. Cellular cast like RBC cast, WBC cast, epithelial cast, and they are always pathological, and it indicates glomerular damage, pyelonephritis, inflammatory process, etc. Non-cellular cast like hyaline, granular, vexicast, it can be seen sometimes in normal urine, or it is mainly suggestive of tubular damage, not the glomerular involvement. While the cellular cast suggests some glomerular involvement and pigmented cast because of pigments. So this is an interesting case. I had a 5-year-old boy with pneumonia who got given ceftriaxone and amikacin for the same. And over the next 5 days, the chest symptoms of pneumonia improved, but somehow his creatinine had risen from 0.7 to 2.8, despite the sepsis was improving. His urine analysis showed 1+ blood and leukocyte esterase being 1+, negative nitrite, but a white blood cell cast. Patient was non-oliguric. Symptomatic treatment was continued, but his serum creatinine remained persistently elevated with subnephrotic range proteinuria, with normal C3, C4, all autoimmune diseases were ruled out. So kidney biopsy was done to know the reason, and it showed the tubulointerstitial nephritis. He did have acute tubulointerstitial nephritis because of drug. And if you go back and see, the urine did show white blood cell cast, which was suggestive of some major event happening at the level of glomerulus. So that kid did receive immunosuppression because of that acute TIN, is doing better. This is again an 8-year-old girl who was admitted with me after collapsing during Garba practice because of dehydration. She appeared severely volume depleted and she did receive aggressive fluid resuscitation. On presentation, she did have a bit high creatinine because of pre-renal issues. Her sample showed many hyaline and granular cast. So what is the significance of this cast? So hyaline cast can be there because of renal hypoperfusion, and granular cast suggests some more severe damage to the tubules in the form of acute tubular necrosis. So here I am sharing 2 reports of 2 patients. If you see on the left side, which is showing hyaline cast, this was a 6-month-old kid who had severe hypernatremic dehydration and urine showed hyaline cast. And at the same time, if on the right side, there is a patient who did have hematuria because of ibugesic induced, and that was some granular cast. So and there was also protein was there. So hyaline cast is usually okay. It is showing hypoperfusion, but granular cast is something you should be worried about the more intense damage in the form of ATM. So this is again a very useful table to know different cast leading to different etiology. And the last but not the least, crystal. Urine made crystal clear at the end of this slide. A 6-year-old male child evaluated for fever. His urine showed 2 to 5 pus cells, 5 to 10 RBCs with calcium oxalate crystals. Ibugesic was given. So next step will be just to document urine calcium create ratio, because though this RBC can be because of ibugesic, but oxalate crystals, so it's always better to document. So crystalluria can be found in both pathologic and normal state. Almost 15 to 20% of asymptomatic healthy patients with no history of kidney disease will have some form of crystalluria. And always crystalluria doesn't mean stone, but as I said, you have to evaluate properly if there is associated family history of stone, etc. is there or not. So this is the clinical significance. If you find calcium oxalate crystals, it can be seen in normal. If you are having amorphous phosphate crystals, it can be because of veg diet, amorphous urate because of diet, again uric acid crystals because of diet. Staghorn crystal is definitely pathologic, and cystine crystal again is pathology. So basically, crystals and cast, though they give us useful information, we don't see them normally documented. Why? Because to look for crystal and cast, the urine should be kind of examined within 2 hours, which is usually not the case many a time. So I have just taken this slide to complete the proper urine, that there are whole lot usefulness of urine electrolytes, urine create, urine osmolality to diagnose all those tubular disorders, diabetes insipidus, nephrogenic DI, central DI. And the take-home message is urine collection and transport is really very important. Urine by dipstick is indeed a useful tool. All pyuria are not urine infection, and all that is red is not blood in case of urine. Cast and crystals do give valuable information if interpreted correctly. And urine routine is indeed not that so simple, but I have tried to make it a bit more simple. So with the power of nephrology, we can again make the diseased kidney smile and happy. Thank you. Thank you.
Thank you, Dr. Jalpa. Excellent talk, as was expected. You really made us all realize that routine is really not so routine as far as urine examination is concerned. So many aspects you have covered.
Yes.
Questions from the audience? We have Dr. Geeti with us if she has any comments to make. She is a very well-known microbiologist in Vadodara.
Good morning, everyone. And Dr. Jalpa, that was indeed a very, very, very good and very insightful talk. And I'd just like to comment on one thing
Yes.
that when we have urine routine is normal, but culture is positive in about 20 to 30%, about 30% of cases.
Yes.
And the reverse is also true.
Yes.
That when you have pus cells but you don't have any growth, that is also common in 30% of cases. So
Yes.
when you suspect infection, one shouldn't go for only a urine routine and then expect something to turn up and then go for culture.
Yes.
If you suspect infection, you should go for culture straight away. So I've seen a lot of people doing this, that they get a urine routine done, then they wait, then they say, okay, culture SOS. But then 30% of times means like 1/3 or so you're missing out, right? Because you're just relying on your urine routine. So don't do that. If you suspect infection, always get a culture done. So
Yes, yes.
that's the comment.
Yes, yes, definitely. So
Yeah.
if we are suspecting UTI, then definitely we should straight away, and that will help us for giving the first dose of antibiotic, because if you wait and then again the culture will be sent after receiving antibiotic. So if you are clinically suspecting UTI, especially in pediatric, it's always better to send both simultaneously. Having said that, sometimes, especially if you are having asymptomatic bacteriuria because of all those catgut condition, and then just treating those because the culture is positive, and when you have not checked whether it was collected properly, because in pediatrics the collection technique is equally important. So that is also very true, that you ask the parents how they have given the sample to the lab and how they have collected.
So, Dr. Geeti, in pediatrics, we need to keep a very high index of suspicion in younger infants. Older children,
Right,
if
sir.
urinary symptoms, it's very easy to suspect UTI and then both routine as well as culture. But in infants, usually when we are dealing with an infection, we need to have a very high index of suspicion, and there we always go for urine routine as well as culture, especially in neonates and infants below, say, 6 months of age. So
Right,
that,
sir. And sir, because we've also learned, like when we see plates, then we understand that this sample was probably not collected well enough. So we've made it a practice in our lab that whenever we have an infant, then we always give them a separate container and say, okay, if this sample doesn't turn out to be good enough, we'll collect a fresh one from you tomorrow. If the lab says that this sample was inadequately collected or was showing some degree of vaginal contamination, especially in female children, or in it's a mixture. So instead of people giving out unnecessarily 2-3 mixtures of organisms, it's better always to repeat. So we repeat free of cost, and then we process the second one or sometimes even the third one. So it's actually a big challenge. And we always give these instructions, like Dr. Jalpa had mentioned, that after a feed, you kind of give the baby some sounds, su type of sounds, and then the baby will be able to pass urine. And like she said, you have a couple of containers. So like to the other pediatricians and physicians who are also here, whenever it's a baby who needs to have a urine sample collected, you always take multiple containers from the lab and then try and collect. Because if the container is open also for a longer length of time, then that also leads to contamination. So you have to collect at one go. And about 10 to 20 ml is enough. 1 or 2 drops doesn't give you a good enough answer. So that's not adequate. Right. Thank you.
Dr. Jalpa, I don't know whether I missed on it or not. Did you mention about seeing bacteria in urine microscopy or doing gram staining of the same?
Yes, sir. So again, because all this cast crystals as well as bacteria, it should be immediately processed. So nowadays, different, it can be for gram stain to know the bacteria, or sometimes to know the eosinophils. There are various stains are there. So bacteria present it shows that they have symptoms. So it's basically correlated with pus cells and urine infection. So if bacteria is there, one need to go if clinically proven to diagnose the UTI.
That's only in a fresh urine, right? Fresh
Yes.
sample.
Fresh sample.
Any other questions? Okay, so there are no questions or comments. I think we end the session here. It's already 9 o'clock. So thank you very much, Dr. Jalpa, for very informative talk. Thank you all for joining. We meet next Saturday morning again. Thank you. Thank you.
Thank you, sir.